I was given the task to speak about the treatment of multiple myeloma in the first relapse. My name is Ahmed Alhuraiji from Kuwait Cancer Center. So we have a lot of questions here about the best combination. I think we have heard a very good talk by Dr. Majid Al-Ahmadi speaking about the quadruplets and triplets and all the novel agents in the frontline setting. So we have to be cautious on what to use on the next line of treatment in patients with multiple myeloma. The questions also continues on the definition of the len-refractory patients, the choice of therapy, especially now the daratumab is moving into the frontline setting, and what do we have in the second line? The role of second transplant is also controversial, and sometimes we go for a second auto transplant. So whom are the patients that we are transplanting in the second complete remission? Also we are faced with patients with extramedullary disease, secondary plasma cell leukemia, patients with renal failure, and cardiac patients. So the choice of therapy here is very challenging. We have main principles on choosing the second line of treatment is basically the age of the patients, the comorbidities, the performance status, and what prior therapy did he receive, and what was the responses and the duration of the response. Not to forget also the disease biology and the high-risk cytogenetics, as well as the presentation to start with initially, whether he had an extramedullary disease at the diagnosis, whether he had a circulating plasma cell at diagnosis. That will signify a very high-risk and ultra-high-risk disease. In 2022, we have plenty of options. We have the IMiDs, we have the proteasome inhibitor, we have the chemotherapy, we have the novel agents, and more recently we have the immunotherapy in the form of CAR T cells and antibody drug conjugate, as well as bispecific T cell engager. What we have in Kuwait is and I believe in most of the countries in the Gulf, is the immunomodulator, the thalidomide, lenalidomide, and pomalidomide. We have all the proteasome inhibitors, starting from the Velcade to ixazomib, chemotherapy as well. We started to use the daratumab since probably 4 years now, and we don't yet get the sub-Q daratumab. And I believe the other monoclonal antibodies like isatuximab is coming into the market soon. We didn't start it yet in Kuwait, but it's coming probably by the next month to start it on the first patient. I think this was shown by Dr. Majid Al-Ahmadi. The treatment of patients with multiple myeloma is not a sprint, it's a marathon. So you have to be strategic and have some techniques to choose the best options of the patients. So usually the first remission, as Dr. Majid has mentioned, is the longest one, and then you have to plan it from day one at diagnosis to plan the first, second, and probably third line of treatment. So I'll start with a case here, a 68-year-old man who had a multiple myeloma. In Jan 2022, he was treated with RVD into 4 cycles and then RD because of peripheral neuropathy. He underwent auto-transplant in Kuwait in October 2020. He achieved complete remission at day 100 post-transplant and started on len maintenance post-transplantation. He was found to have also hepatitis B surface antigen, and he had a positive family history of multiple myeloma. During follow-up, we can see that the M band starts to show up now. In October, it was 1.2 and increased to 3. And then more recently, 2 weeks ago, it was around 6.8 gram, as well as his light chain. So we upped the dose of the lenalidomide initially, and then we introduced the dexamethasone. We discussed him in our MDT. The plan is to do imaging for him to repeat his bone marrow biopsy and see. So the definition of progressive disease, as per the IWG criteria, is to have more than 25% increase from the nadir, either in the M band or free light chain, or if the patient has non-secretory myeloma based on the bone marrow plasma cells, or based on the imaging if you have new lesions. Circulating plasma cells also indicate a relapse of the disease. So we have different definitions: the relapse refractory patients who were in treatment and then had a minor response, then progressed. The primary refractory patients did not achieve even a minor response in the first line treatment, and the relapsed myeloma patients who meet the criteria for progressive, but not for relapse refractory or primary refractory. We don't treat all relapsed myeloma, so the indication for treatment at relapse, either if you have a clinical relapse or you have a significant biochemical progression, meaning that you have either CRAP or you have a significant biochemical progression based on the parameters like the doubling of the M band, the light chain, as well as the M protein in the urine. So based on the ESMO 2021, the treatment in the first relapse for patients who relapse after VRD, since it's been the standard of care for many centers nowadays, is to see whether the patient was LIN or Velcade refractory. And you can see here that the level of recommendation is almost 1A for everything, like the KRD, DRD, LORD, POM-VD, and DARA-KD, or AZA-KD. This is for LIN-sensitive patients. So the definition of LIN-sensitive is also variable, but we usually use the International Working Group for the LIN refractoriness. So if you have a LIN refractory patients, either then you move to DARA-KD or isatuximab with carfilzomib, dexamethasone, or pomalidomide, Velcade, dexamethasone. However, in patients who had failed DARA-RD or DARA-VMP, since being approved in the frontline setting for transplant eligible, here we don't have data to support the use of other monoclonal antibodies like isatuximab in this setting. Therefore, we use other agents like the proteasome inhibitor or the immunomodulator, the next generation. And we use them in combination. The NCCN guidelines also recommended in all category 1 as well, the KRD, DARA-RD, DARA-KD, and DARA-VD, or isatuximab along with KD. That's all in category 1 recommendation. In MSMART guidelines as well, they also, the first relapse, they will take it into like LIN refractory versus LIN sensitive, and then for LIN who had not refractory to lenalidomide, then the option is to go for DARA-RD, or if they are DARA refractory, to go for KRD, or if they are very frail patients, they will go for ixazomib, Revlimid, dexamethasone. For patients who were refractory to lenalidomide, then the choices are DARA-KD or DARA-PD, or AZA-KD, AZA-PD. So we'll start to see the data. What does it tell us? So we have the CANDOR trial. The CANDOR trial tested the relapsed refractory patients whom were evaluated the use of DARA-KD versus carfilzomib, dexamethasone. So this is the recent analysis. After a median follow-up of 27.8 months, we can see that a clear progression-free survival in favor of DARA-KD, 28.6 months compared to 15 months. And this was planned for overall survival, but the data was not mature to test the overall survival. And what about the anti-myeloma therapy following the progression in both groups? We can see that most of the patients in the KD arm were to receive anti-CD38 monoclonal antibodies, and patients who had failed daratumumab, they will move into like anti-PCMA therapy, for example, CAR T cells. If we take a subgroup of patients who were treated in the first-line setting in the CANDOR trial, based on their prior exposure to the lenalidomide, we can see that the lenalidomide exposure did not impact the response rates in patients treated with DARA-KD. So we can see a very high response rates up to 90%. And this is the median time to next treatment in the CANDOR trial that we can see in LIN refractory patients, whom we think that they are very, very high-risk patients, is around 28.8 months. Moving into the POLIX trial, the POLIX trial has tested the DARA-RD versus RD, and if we can see the standard risk patients, for all patients, the median progression-free survival was not reached for the whole population, but even in the first patients who had one-line therapy, the progression-free survival was higher. And the high-risk cytogenetics here was translocation 414, 1416, or DEL17. For high-risk patients, we can see a lower median progression-free survival for DRD, aiming to 26.8 months, and patients who had received one line of therapy is around 29 months. This is after a median follow-up of 44 months, almost 4 years. Very important to remember that patients with LIN refractory were excluded from this trial, so we cannot apply patients who were refractory to lenalidomide to use Pollux trial on them. So the prior LIN exposure was allowed, and you can see that there is a clear benefit in the multivariate analysis as well. What about the CASTOR trial? The CASTOR trial tested the DARA, Velcade, dexamethasone in comparison to VD, and this is a median follow-up of 40 months that was published almost 2 years ago. And we can see that the median progression-free survival for the whole cohort is around 16.7 months. In patients who had received one line of treatment is around 27 months. Patients who were LEN refractory, they had a dismal prognosis on the CASTOR trial with a median PFS of 7.8 months. And this is the baseline characteristics for DARA VD. Moving into the second generation monoclonal antibodies like isatuximab, the IKEMA trial, we have two trials tested the isatuximab, the IKEMA and the ICARIA. The ICARIA study did not include patients in the first relapse, so they had to have like 2 or more line of therapy. So we can't apply it into our question for today. So if you can see, the overall response rate was higher in both groups, around more than 80%, but deeper in patients treated with ISA-KD and higher MRD negativity rate. The median progression-free survival after almost 2 years of follow-up is not reached yet in the ISA-KD arm. BOM-VD, pomalidomide with Velcade Dexa, was tested also in the Optimism trial that included almost 600 patients. That we can see that patients for the whole cohort, the median progression-free survival was less than a year. But if we take it for only patients who had received one line of therapy, the median progression-free survival almost 2 years. KPD, the carfilzomib pomalidomide dexamethasone, we tend to use it quite extensively in patients in the relapsed refractory setting. However, this is an off-label indication, and based on a very low level of evidence, we have a phase 1-2 trials testing the carfilzomib pomalidomide dexa. The first trial was published in 2015, testing the twice-weekly approach with carfilzomib, and as you can see, that the patients were heavily pretreated. They had 2 or more lines of therapy with a median line of therapy of around 6 lines. All were LEN refractory, and the overall response rate was 50%. The complete remission was 0%. The median progression-free survival was 7 months. But if we move to the patients who had 1 or 3 lines of therapy, we can see that the overall response rate has increased to 2/3 of the patients, and the median progression-free survival was also improved. The tourmaline MM1, this is a study. I think it's very feasible for patients who've been frail, elderly, because especially during the COVID pandemic, because you tend to give like a complete oral protocol, including the proteasome inhibitor, the ixazomib, Revlimid, lenalidomide, and dexamethasone. So we can see here the overall response rate was almost comparable between the two, but we have a very deeper responses with the IRD group and a very faster response as well. It's worth to mention that LEN or bortezomib refractory patients were not included in this trial. So in the first analysis that was published in 2016 in the New England Journal of Medicine, there was a clear progression-free survival advantage in the ixazomib Revlimid dex, and we can see it in patients, especially in high risk in the first-line setting, and patients who are elderly as well. But if we can see the final overall survival advantage or analysis that was published more recently in the JCO, we can see no overall survival advantage for the whole cohort based on the intention to treat population. But if we can take the high-risk patients based on the cytogenetics, we can see that the median overall survival was 47 months compared to 30 months. So there was a clear evidence that it might be beneficial for patients who have high-risk cytogenetics. This is a cross-trial comparison for all the studies I've mentioned. Just for your review, if you can share the slides later. What about the role of salvage auto-transplant in the setting of relapsed multiple myeloma? The EBMT ASTCT guidelines in 2015, they suggested that the second transplant can be offered for patients who had an initial remission for more than 18 months. But the ESMO guidelines in 2021, they said if the initial response was more than 3 years, then the second transplant can be offered. The MSMART guidelines have a little bit of a detailed guidelines. They said, consider salvage auto-transplant for patients who did not receive it. That's okay. But patients for a second auto-transplant, if the remission duration is more than 18 months, but the patient did not have any maintenance therapy, you can offer them a second auto-transplant. Patients who were maintained on maintenance and they progressed, then the remission duration should be more than 3 years. So I'll go for some special scenarios. Patients who had an aggressive relapse, like extramedullary secondary plasma cell leukemia, usually they have a dismal prognosis. Patients who have an extramedullary disease, their median OS is around 6 months. Patients with secondary plasma cell leukemia is around 4 months. And we have to incorporate chemotherapy in this setup. And if the patient did not have autologous stem cell transplant in the past, it's better to offer them a auto-transplant. So we can see here that the factor affecting the extramedullary relapse, if they have extramedullary disease at diagnosis, that will tell us that this patient might have an extramedullary relapse later on. If they have a high-risk disease based on ISS stage 3, patients who had auto-transplant in the frontline treatment, then the risk of extramedullary relapse later on is lower. And this is, I found it more recently that there is a limited efficacy of daratumumab. We think that the monoclonal antibody might improve the outcome in patients with extramedullary disease. The fact is not that patients who had an extramedullary disease, if they were treated with daratumumab, then the median OS is around 4.6 months. Did not change from the historical data we have. So if we have a relapsed CNS myeloma that we sometimes see from time to time, it's rare, but if it happens, then these are the options for treatment. So the IMiD that can penetrate the blood-brain barrier. The proteasome inhibitor are poorly penetrating the blood-brain barrier. We have some data on the daratumumab to penetrate the CSF. But so these are the options for patients whom you think that they have CNS myeloma. Patients with renal impairment. So for IMiD, you need to adjust the Revlimid dose only. For proteasome inhibitor, the ixazomib maybe needs to dose adjust. You don't need to do any adjustment for the monoclonal antibody like the dara, isatuximab, or elotuzumab. The cyclophosphamide and melphalan, they need dose adjustment with patients with renal failure. So the take-home message here, the relapse in multiple myeloma is common, and the biochemical relapse is not always an indication to start therapy. Evaluate the aggressiveness and comorbidities of the patient at the time of relapse, and use triplet if possible, preferably monoclonal antibody-based, if not used in the past. Patients with extramedullary disease and secondary plasma cell leukemia usually have a dismal prognosis, and the need for multi-agent chemotherapy is required. Immunotherapy that we have some early data, they are very promising, and hoping it will change the outlook of patients with multiple myeloma in the near future. With that, I would like to conclude, and thank you so much for listening.